Okay, so this is Mr. Beasy. He's a 68-year-old male patient, retired mechanic, who's referred for symptomatic anemia for 6 months. He has a history of stage 1 colon cancer that was resected without any adjuvant chemotherapy 5 years ago, as well as hyperlipidemia. He's only on atorvastatin, no smoking, no alcohol history. His father did die of AML at the age of 90. His hemoglobin when he comes to see you is 8, but that's transfused. White count's 3, neutrophils 1.8, platelets are 120. He's macrocytic and has anisocytosis. And when you trend his blood work over time, it's been progressively declining, but he's only been transfusion dependent for the last 6 months, for about 2 units every 4 weeks. His EPO level is elevated at 450. He's transfused every 2 to 3 weeks. And so by the time he sees you, he's had a total of 18 units of red cells. His ferritin's elevated, iron saturation's creeping up. And from a physical point of view, because it's all about patient factors as well, he used to be an exerciser, but now he's sedentary because of dyspnea on exertion. He's mildly overweight, and we've ruled out all reversible causes of his anemia. He does have some suspicious ovomacrocytes and occasional hypogranular neutrophils. His bone marrow, however, is hypercellular, but he does not meet the 10% cutoff for calling dysplasia, and there's no excess blasts. His karyotype is deletion Y, and by NGS, you have a SRSF2 mutation with a VAF of 20% and an IDH1 mutation with a VAF of 10%. So he is diagnosed with CICAS. So my points that I'd like to be addressed by the panel are what is his risk of developing an overt myeloid neoplasm in the next 5 to 10 years? How would you treat him? He's transfusion dependent. He has a high EPO level. Is there a role for hypomethylating agents, for example, even though he doesn't have a diagnosis yet of MDS? When would you consider allotransplant for somebody like this? How often would you repeat a bone marrow to monitor? And if we change the NGS panel to just a single DNA MT3A mutation at a VAF of 18%, how would you manage him? And I'll pass it over to Jane, who has a similar CICAS case, and then it will be open for discussion.
Great. Thank you so much for the opportunity to present this case today. It dovetails nicely with Rena's case. So this is a 66-year-old gentleman in my practice with pancytopenia, and he actually has had pancytopenia that I could document for at least 10 years. He had been getting intermittent transfusions over time when he had drops in his blood counts. You can see those to the right. His hemoglobin at baseline was around 11. His absolute neutrophil count was 340. His platelet count was 46. He also had intermittent pneumonias, and more recently had developed worsening splenomegaly and lymphadenopathy that was non-diagnostic for any other alternative malignancy. In addition, he had these inflammatory issues. So he had developed Sweet syndrome involving the skin and pleural effusions a couple of years prior that was treated with steroids for about 5 months and was resolved. However, he continued to have these intermittent chest pains that had no diagnosis, and he was developing subcutaneous skin nodules that would come and go in different locations on his legs. He also had a very chronically elevated ESR and CRP, which you can see to the right, with a CRP elevated at 10.4, and his SED rate is 55. His other relevant medical history included a mild learning disability, and he had had Graves' disease and required radioactive iodine in 2009. Next slide.
You can push it.
Got it. His peripheral smear had no morphologic abnormalities, and his bone marrow biopsy was variably cellular, around 30 to 50%, with morphologically unremarkable trilineage hematopoiesis and 3% blasts. His karyotype was of interest, so he'd had prior karyotypes that all showed a translocation of 14 and 21 that was thought to be constitutional. And more recently, his marrow this year showed a ringed chromosome 7. His myeloid malignancy panel showed an IDH1 alteration at arginine 132 serine with a high variant allele fraction at 42%, and a DNMT3A missense mutation with a VAF of 27% that was called a variant of uncertain significance by our molecular pathologist. Because of the longstanding pancytopenia and his intellectual disability, we did a germline genetic workup, and he had a large interstitial duplication involving 7.6 megabases, and this included 66 total genes, including a complete duplication of GATA2 and MBD4. His diagnosis was CCUS. Ooh, that went the wrong way. So because of his inflammatory issues and his cytopenias with complications, we decided to look for a clinical trial availability. And fortunately, Dr. Kelly Bolton is leading a trial out of WashU, NCT 0503041, which is a pilot study of ivosidenib for patients with clonal cytopenia of undetermined significance and mutations in IDH1. This is a multi-center, open-label, decentralized study, which means that the patient goes there once to enroll, and then they are treated locally, and they receive 500 milligrams of this drug per day. And their primary endpoint is the rate of improvement in hematologic parameters, and you can hear more about this trial on this ASH meeting on Sunday. So you can see here, with permission from Dr. Bolton and the drug company, this is my patient's response on this drug. So on the top are his inflammatory markers, ESR and CRP, and on the bottom are all of his cytopenias, which you can see there's a kind of a prolonged 1-year period of data first where they're very stable. And after he starts this drug, his inflammatory markers come down quite dramatically and his blood counts start to improve. So to look at this in more detail, after 3 months, his hemoglobin has increased by 2 grams. His neutrophil count went from 340 to now 2,300, and all of his inflammatory markers have normalized. He has so far tolerated this drug pretty well. He has subjective improvements in his fatigue. The chest pains are only now once to twice per month rather than multiple times per week, and he has not had recurrence of these skin nodules. The only potential side effects he has had so far are a self-limiting rash, which you can see images of, and a weight gain of 14 pounds, but without any other signs of differentiation syndrome. Thank you.
Yeah. So going back to my initial case, the question is, how should CCUS, high-risk CCUS, because if we use the CHRS prognostic score for my patient, he was considered high risk. How should we be treating somebody who has already transfusion dependence? So it's not just pancytopenic or anemic, but is actually experiencing deep cytopenias and symptomatic cytopenias, and how would we manage them? So this is very interesting about the IDH1 inhibitor working in this particular patient, but in some cases there's no actionable mutations with high-risk CCUS, and how should they be managed?
If I may start, so you will quickly understand that I'm not a conservative, as you might have thought before, but I'm rather progressive, thinking that actually the diagnosis of myelodysplastic syndromes needs to be revised. And Mario has already given a talk on that. But I think that a patient where you take a bone marrow and you look into the bone marrow, and with your eyes, which let's face it, may not be, the absolute expert eyes for myelodysplastic syndromes. You say, well, it's not that many dysplastic changes in this bone marrow that I think. It's not 10%, it's only 8%. I mean, come on, okay? And the patient is transfusion dependent, and he's got for instance, chromosome 7 abnormality, or has several mutations. I think we should call these patients MDS and not CCUS, okay?
What is the line?
Excuse me?
Where would you put the line?
I don't know. I think we need to discuss this. I think we need to discuss this. But the patients that have been presented here, in my opinion, are now being classified as CCUS, but in fact they have MDS. They should even be considered for curative treatment, including allogeneic stem cell transplantation. I mean, we know from the second case that IDH inhibitors may improve their blood counts, but we don't know for how long. We don't know what the clonal pressure on those cells are, and whether additional mutations will occur that then turn the whole thing into high-risk disease, which is going to explode in front of our eyes. So my first point would be, I think Mario and others, we need even more refined classification, and we need to think about CHIP and CICAS, etc. Once the patient becomes treatment dependent, transfusion dependent, etc., these patients should be called what they are. They should be called myelodysplastic syndromes and should be called at high risk of developing full myeloid disease, and that may actually lead to death, because then we can discuss allogeneic stem cell transplantation. And with that, I would turn either to ChatGPT or to Lou Silverman.
Well, I agree with you. All right. I think if I can quote a famous author, a rose by any other name. And I think that although this patient is not being classified as MDS based on some lack of morphology, the dynamics of the marrow have placed this patient in a position where their marrow is failing. It's become transfusion dependent and symptomatic, and to a high degree. And so I think that, you know, in the past we had issues about where does MDS and AML, where are we drawing the line? And we argued for a lot of years about 30%, 20%, 10%, and I think the line between CHIP, CICAS, and MDS is going to be the same kind of moving target that we're going to have to contend with in the future. And I think that the course of disease, the presentation of the disease, is going to have to inform some of our therapeutic decisions. And we, I think, are still lacking the understanding of the dynamics in the marrow for CICAS versus MDS. I think there are some patients who have clonal hematopoiesis with cytopenias, where the cytopenias may be related to other factors that are beyond just a stem cell failure, that are contributing to the cytopenias. And we need a lot more data and studies on these patients to make decisions. So, you know, I think this patient does merit therapy. The question will be what type. And I'm not sure that I would be enthusiastic about jumping to transplant for this patient just yet, but somewhere down the road that might be a consideration. But I think the definition is in textbooks is very arbitrary. In real life, it's a moving target, and I think that's the challenge for us with these kinds of patients.
The second thing I would like to point out is that the second case is most interesting because the patient has slight learning disabilities. The patient has some kind of immune disturbance, and the patient has a constitutive cytogenetic abnormality. So here we are getting into some very muddy waters. We are getting into something where you have already a original abnormality in the bone marrow, which is constitutive, and that adds, you add mutations to something that is abnormal from the beginning. So this becomes even more challenging. I mean, I find it wonderful that there is a possibility of treating patients with CICAS and IDH mutations. We see that it has worked, but I think we are here in the field of constitutive abnormalities with higher risk for myelodysplastic syndromes and acute myeloid leukemia, and that is something that is being recognized more and more, especially because of our abilities to do genetic abnormalities, but needs also to inform us that at some point we need to jump in and do something about it. And I find it wonderful that the patient responds, but I think, and I agree with Lou, that down the road, this patient is probably going to, at some point, become a candidate for allogeneic stem cell transplantation.
I have a comment and a question. The comment is that we as physicians, we should take responsibility and we should be aware of the fact that these are not only words. The definition means to the patient in terms of coverage, insurance, and these issues. In many countries and many systems, if you define the patient as CCAS, probably the regulatory agencies would not know what you are talking about and the insurance would not cover. Once you say MDS, probably it means more, and sure, as Lou mentioned, I think, yes, the numbers are just arbitrary, but these patients who need treatments are not healthy people. They are sick and they need treatment. So I think we should remember this as physicians. The question that I have to you guys, considering that, and I think Michael gave an excellent talk about the relation to inflammation, and the second patient was also associated inflammatory, and we all see patients with high saturate, high CRP. We don't have yet, in the year 2023, yet still good studies, and Michael, I think, mentioned the IRAK4 inhibitors and so on. Would you treat these patients with, as Rina also asked, statins, Advil, any other anti-inflammatory agents, just to give them the chance probably to delay the process? What's your thoughts?
Maybe I can anecdotally add something. My father had a heart attack at 56. And my grandfather had a sudden heart death at the age 64. And so my wife said, don't you want to take your LDL levels? So I took my LDL levels, came out 150 with a normal of 160. And then she said, why don't you take your LP lipoprotein A level? So I took my lipoprotein A level, said, what is that? And she said, well, it's also a marker of, heart disease, and that was elevated. So she said, you should take a statin. So I said, okay, which one? She says, you should take a rosuvastatin 5 milligrams. So I started that. After 10 days, I thought I had a renal calculus. I was going goodness gracious, etc., etc. So I did all the investigations, and there was no renal calculus. It was actually a side effect of rosuvastatin with muscle cramps, one-sided muscle cramps, etc. So, we are tending, I just want to make cautious, we are tending to treat patients. We say, you give him this and give him that and give him that. Unless the patient is really ill, I would refrain from using drugs, prophylactically like that, because they have enormous changes. They are not very specific, these drugs. Well, whatever drug we're talking about, but the HMG inhibitors anyway. But here in both cases, we have strong evidence that there's something wrong in the bone marrow. And this that is wrong in the bone marrow has led to transfusion dependence. These patients will go down the tube. I mean, Rina recently showed it, and Matteo and others have shown it in the past. These patients don't do well, so they need something to be done. And therefore, I agree with you. Call them MDS and treat them as MDS, and probably treat them as higher risk, low risk MDS.
Jane?
Yeah, great, thanks. I was also going to say that I agree with Lou that this line between CCUS and MDS is definitely very arbitrary when you see the behavior of the patient and they need some sort of intervention and you have no access to it because of the definition of their disease. So I was really excited about this type of clinical trial that's decentralized, where you can access this, especially as we dice our patients into different smaller and smaller molecular bins, and it's hard for them to get to single centers. The other comment I would make is about the germline. So Rena's case, the father also died of AML. And so in the CCUS clinic, I'm sure Michael has noticed, there's a lot of familial risk in those patients. So there are a lot of germline factors driving these CCUS patients, CHIP patients. And in the germline space, there's a lot of really interesting data explaining the molecular reason for some of the acquired alterations. They bypass the underlying deficit. And in some cases, there are potential targets for drugs. And so I think, that is definitely a very important area to continue to gather data on, because hopefully someday that will allow us other therapies that are specific to those patients.
Any comments from the audience? If not, we are going, yes, Michael? No? Please.
Chairman there. Yeah, so Michael Savona. So I like the cases that you chose. I think that they were, you could select people who are much less sick and make this more difficult. But I think both of these patients really have bad disease. They have high-risk mutations. Interestingly, the first one, I think Rena's case, I was going to make the same comment about the germline. That really worries me about a DDX41, for example. But, we make the decision on who to transplant and who not to transplant based on Corey Cutler's IPSS stratification 20 plus years ago. And, these intermediate ones don't get transplanted, intermediate twos get transplanted. This is an IPSS-M high-risk patient. I mean, I eyeballed it, I didn't calculate it, but it looked like a high-risk patient by IPSS-M and a lower-risk patient by IPSS-R. And we let insurance kind of guide us on how we make the treatment, but the writing is on the wall. And that patient, 68 years old, may have a couple years left of transplant eligibility, and then they lose it. That patient will develop acute leukemia, and the time to transplant them is before they get acute leukemia. So that's my comment. I just wanted you to maybe answer a comment that, your perspective, how you feel about transplanting people who are IPSS-M high risk, who are IPSS-R lower risk, or IPSS lower risk, and, the pickle that we're in there.
Well, I think that's an excellent question, and I think it's one of the challenges for MDS, and the challenges are actually becoming greater. For years, I've said that no two MDS patients are identical, and that just reinforces the heterogeneity that we deal with every day in these patients, and the individual behavior is very different. And so making those decisions is challenging. I agree that the Rena's patient is really MDS and, just lacking the dysplastic features. And maybe if you gave it to another pathologist, maybe there would be 12% dysplastic cells and make the criteria. I think that in our institution, we'll transplant patients easily at the age of 75, and some patients gone up to 79. So we're not quite as restrictive. This patient could respond. If you use the CCUS classification, the patient does classify out as high risk. But if you go by that classification, there's only a 50% chance of developing a myeloid neoplasm. I think this patient already has that. And so I think the CCUS classification is probably a disservice to this patient. But I think that I would probably try alternative therapies, but monitor this kind of patient very closely, and then see where I would jump to a transplant. But I'm probably not at this point yet for a patient who's untreated.
Thank you.